Hi everybody, welcome to this presentation, and this is going to be about the vagus nerve in connection with the breath, and also going into a couple ideas of practical exercises for working with kind of resetting the nervous system. I know a lot of you are working with different forms of cognitive therapy in dealing with emotional issues, that kind of thing. And I'm certainly not an expert in that. And why I was asked to do this presentation was to augment with some ideas about simple exercises of physical reset as well as breath awareness that people can do for themselves. And throughout the presentation, I try to give, as much as I can, citations of the sources of this material. So if you want to follow up on it, you can. Some of the sources work more on the side of psychology and cognitive therapy, and others, Stanley Rosenberg in particular, works from the perspective of a cranial sacral therapist. And I'm not a cranial sacral therapist either, but the exercises that he uses with his patients and offers to psychotherapists are simple self-treatment techniques that have proved to be effective, because he points out that most psychotherapists are not licensed to essentially touch their patients or physically interact with them. And so he's offering to them these sorts of exercises that, once again, patients can do for themselves. I know we got a wide range of expertise in the group joining here. I'm going to err on the side of simplicity and try to define my terms so at least we're all on the same page, though a lot of the terms may already be familiar to you and you may have quite a bit of knowledge that goes beyond mine. We kind of titled this Understanding Breath and Emotion, but it's from the perspective of talking about the vagus nerve and the autonomic nervous system, bringing in new insights into the understanding of the vagus nerve and its role in the autonomic nervous system that have been introduced from the 1990s onwards by Stephen Porges. And this is called the Polyvagal theory. And it's controversial kind of on the micro level. Some of the science regarding the actual nerves and down to the cellular function are called into question here and there by different researchers and scientists. I'm not going to address that or get into it. What I do find is that this theory has proved to be very clinically useful, both to Stanley Rosenberg as a cranial psychotherapist, and also many of the therapists, including the ones mentioned here, who use this model for working with their patients, even on a cognitive level. So the details may be controversial, but it's proving to be a useful and insightful theory that's helpful in many fields, including interesting applications to autism and people on the spectrum of autism. And if you're interested in that aspect of it, I recommend starting with the chapter in Rosenberg's book, which is cited in here, where he goes into his work on it, with it on a physical level. And Stephen Porges, who introduced the polyvagal theory, also does a number of modalities working with autism, especially through sound and other things. So there's actually a wide range of applications which are proving to be useful. So to kick it off, just to lay out the terms, we are here talking about the autonomic nervous system, and this has to do with our ability to respond to and recover from the challenges of daily life. And that ability is an indicator of our well-being, and that kind of flexibility and adaptability depends upon the actions of the autonomic nervous system, which we'll see works on a number of different levels. How this aspect of our nervous system interacts with the world is described in terms of a term, neuroception. I'll define a little bit more on the next page, which was introduced also by Stephen Porges, or at least utilized in a particular way. And this is understood as a perception, a sensitivity, a detection via the nervous system without, or in many cases, without conscious awareness of this going on. So it works kind of below or prior to conscious awareness. And the autonomic nervous system listens inside the body to feel reactions, responses, physiological reactions within the body, also listens to cues from the outside, the environment, and also subtle cues in our relationships with other people, facial cues, body language, tone of voice, that sort of thing. It's always collecting this data and bringing it in to make determinations about how to respond in and to that environment. In general, therapies work to reshape the responses of the autonomic nervous system by bringing this implicit process into more explicit awareness, finding ways of bringing into consciousness the way in which we process this data, how it's influenced by past experiences, especially previous traumas and other forms of experience that color our experience of our present situation. We'll see that this faculty of neuroception can be quite correct and accurate. It can also be faulty given past experiences or present conditions. In this webinar, we're looking to add practical tools for self-adjustment that influence the physiological side of this process of communication and response between ourselves, our nervous system, and the world, recognizing that the cognitive aspect and working therapeutically with the cognitive aspect expands even beyond that. But I'm trying to keep it to simple news you can use as additional ways to approach this. So the term neuroception was coined by or utilized by Stephen Porges to describe how these neural circuits assess basically whether a situation is safe or threatening or dangerous, even life-threatening. It's an ongoing process through which the system evaluates information from our senses about our environment and state of the body. It takes place in the deeper parts of the brain, generally beyond conscious awareness, that we're going to look at primarily and especially having to do with the brainstem. Neuroception gives us access to information we don't pick up with the conscious part of the mind. You can think of it as kind of our gut feeling, or what we often refer to as our sixth sense or premonition, that something's about to happen, or something doesn't quite feel right. That gut sense often turns out to be quite accurate. And as I mentioned, neuroception can also be faulty. It can be blinded by emotion, the various kinds of emotion that either lead us to discount or overly enhance this information and thus receive a faulty intuition of danger and also a faulty intuition of security. We can be locked in traumatic memories or triggered into traumatic memories, which in turn heighten our sense of danger when no danger is actually immediately present. And it can also be affected by for physical reasons, by being sick, ill, hungry, dehydrated. All of these things affect this. And it's especially in the case of trauma. Faulty neuroception leads to a wrong assessment of the nature of a situation and pushes us into a reactive state that includes disconnection from the body, as well as an abandonment of healthy social strategies. The person turns in upon themselves defensively and is less available to face the problem or deal with the problem by interacting socially with others, which obviously is a difficulty that therapists are working with. How this process of neuroception comes about, we're also going to call it interoception a little bit later on, happens through particular pathways of communication between the brain and the body. And there's a long history to a sense of the possibility of this. An awareness of the vagus nerve itself goes back to Roman times with a particular doctor, his name is slipping my mind right now, who did autopsies on gladiators and started to locate or become aware of this vagus nerve and what the consequences of dysfunction of the vagus nerve are, especially from gladiators that received neck wounds in battle. But Darwin also understood that the brain and the heart are connected and engaged in a two-way conversation through what was then known as the pneumogastric nerve, which is now called the vagus nerve, or as one of the cranial nerves we'll talk about, it's cranial nerve number 10. William James was also aware of this, and he wrote, "A purely disembodied human emotion is a non-entity." In other words, emotion only exists or is meaningful in connection with the body and the experience of the body. And he went on to say that intellectual feeling, and with that knowledge, has to be connected with a bodily reverberation of some kind. Our physical sensations as well as our emotions inform our knowledge, even our intellectual awareness. And by the same token, the mind, through our understanding, can also exert an influence upon our experience of emotion and even of physical body. And that's the relationship we're interested in here. This early understanding of these two-way conversations between the body and the brain was actually later abandoned in favor of envisioning the brain as the dominant force for directing daily experience. And now we're reassessing that kind of overstatement of the case. And the polyvagal theory introduced by Stephen Porges is going into a more elaborate and insightful investigation of that relationship. And through this investigation, he reestablished the understanding that it's through bidirectional pathways that physiological processes, psychological processes influence our bodily state, and our bodily state colors our perceptions and even our mental processes. So we're looking at the sensory fibers that bring information to the brain, initiating a response, and also how the brain responds in turn. This is that whole next quote, which is talking about pathways that connect the brain's motor cortex to the autonomic nervous system through the vagus nerve, which gives the cortex, the brain, a way to exert some control over these responses, which are basically deeper brainstem responses. This is going to be called a vagal brake that we're going to look at. But to take a look at the vagus nerve itself, the Latin used for the term vagus literally means a vagrant or a wanderer. So it's a nerve that wanders through all the different visceral, vital aspects of the body. It branches from the brainstem into the chest, the abdomen, and regulates the many visceral organs through the throat, organs of respiration, circulation, digestion, and elimination. So it insinuates itself into all aspects of our vital functions. And it's primary in this faculty of neuroception, reporting back to the brain what's going on inside. Other information, of course, comes through the senses and works through other pathways as well. Another term for this that I tend to like to use also is interoception. And with the vagus nerve, 80% of the fibers are afferent sensory fibers, which means they bring information from the body to the brain, and only 20% are efferent or motor fibers. In other words, nerve pathways that carry instructions from the brain back to the body, telling the body what to do. And it's this kind of two-sided relationship with the body in which, through the vagus nerve, through the pathway of the brainstem, we essentially are able to illuminate or perceive what the body is experiencing and report that back to the brain. And with that perception, that illumination, there's also the ability of reflection upon what the body is telling us, and with that reflection, responding. The response can happen on a subconscious, pre-conscious level, and that's kind of our reaction to these stimuli. What we're interested in is how, from a conscious level, we can participate in that process of reflection and essentially put a brake on or calm or moderate overreactions to that stimuli or habitual pattern reactions which are rooted in previous experiences. Between neuroception and interoception, I'm going to treat them as essentially the same, though if we get into the details, I think Porges treats this more as a neurological response. But I'm going to treat it on a simpler level, almost interchangeably. Interoception is this sensing of the internal state of the body. And interoception can be more clearly both on a conscious and non-conscious or pre-conscious level. When you walk up to somebody and say, "How are you feeling today?" and they pause and think about it and say, "Well, actually, I'm doing pretty good," or "I'm feeling a little bit down today." That's a conscious act of interoception, of checking into yourself, that picks up on certain cues. And there can also be deeper cues, perhaps, if you will, of neuroception on a neurological level, that possibly we might even ignore in the process of looking inside and saying, I'm feeling okay today. You're blocking out deeper signals on the level of neuroception that may be contradicting that. And it's that very conflict between the conscious level and the subconscious level that can bring up issues in how we respond to our environment. Responding on a gut level on one respect and on a conscious level on the other, often they come into conflict. Overall, interoception is our process of integrating signals relayed from the body to the brainstem. We'll look at the significance of that. And that allows for a nuanced representation of our physiological state. And again, there can be variations in our conscious concept of that and subconscious. But this is overall important for maintaining homeostatic conditions in the body and potentially aid in self-awareness. We'll talk more about what that homeostatic stasis is. So the vagus nerve itself is one of 12 cranial nerves, and cranial nerves are different from spinal nerves. Obviously, spinal nerves travel from the brain through the spinal cord and exit from the spine out to the body and innervate muscles in particular, as well as organs in the skin, and so on and so forth. Cranial nerves are different because they exit directly from the brainstem itself. They don't pass through the spine. The brainstem, as is illustrated here, sits on the underside of the brain. In many ways, it's our more primitive brain, but not entirely. Some cranial nerves connect the brainstem with organs and muscles in the head, such as the nose, the eyes, the ears, and the tongue. These are going to be involved especially in social interaction and are also directly influenced, for instance, through the nose. That's where a particular cranial nerve comes directly in contact with the very movement and texture of the breath through the nasal passages, which I think is one of the reasons for emphasizing breathing through the nose. As a yoga teacher, of course, we teach that, but even beyond yogic practices, breathing through the nose puts you in much more subtle contact with this sort of primal aspect of our nervous system, very direct contact. Other cranial nerves go through small openings in the cranium. This is what we're going to be looking at, the significance of the pathway through which they path, and it reaches into the throat, the face, the neck, but also the thorax and the abdomen, going down below the diaphragm into the organs of digestion and elimination. There are two aspects that I want to highlight out of these 12 cranial nerves. We're talking primarily about the vagus nerve, but also cranial nerve number 9, the one just before the vagus nerve, is the one that monitors oxygen and carbon dioxide levels in the blood and adjusts the breathing rate according to its perception of what's essentially the pH level of the blood. The pH is determined by the balance between oxygen and carbon dioxide, particularly the presence of carbon dioxide in the blood. And the body is much more attuned to and sensitive to these carbon dioxide levels than the oxygen levels. We actually have more oxygen in our blood than we need at a given moment. What the nervous system is paying attention to are the levels of carbon dioxide to determine the necessity and even the pace and breath depth of our breath according to what it perceives to be the needs. The vagus nerve, cranial nerve number 10, monitors the diaphragm itself. And this is significant because we're looking at the breath, and there are actually two aspects of the breath that pertain to breathing pattern disorders that link into different non-helpful responses in the body that we call breathing pattern disorders. When our breathing patterns don't make proper use of the diaphragm, it will communicate through the sensory fibers in the vagus nerve that something's wrong. You're not breathing properly. Usually when we're under stress, we tend to use the secondary muscles and breathe more with the chest muscles in order to get more breath moving, because we anticipate needing a burst of energy to run away from the tiger or whatever our situation is. And so if there's a perception we're using the diaphragm less, especially in relationship to our use of the chest, or if we're using the diaphragm inefficiently or in a limited way, the vagus nerve essentially communicates back something's wrong. We must be threatened or in danger in some way. And in turn, the vagus nerve and communicating that to the brain leads to a response from the brain and the brainstem, which further affects our breathing patterns and the response of the nervous system. So there are two aspects to breathing pattern disorders, both of which are monitored by cranial nerves: our blood chemistry and the physiological function of the diaphragm. They're closely related, but not the same, and both actually need to be addressed in working with the breath in conjunction with emotion. Now, in traditional treatment of the autonomic nervous system, again, this is recognized as being central to our visceral automatic functions: digestion, respiration, sex drive, reproductive function, so on and so forth. There's always been, or long been, a distinction between the sympathetic and the parasympathetic branches or aspects of this model of the nervous system, or basically two circuits of the nervous system, and we go back and forth between these circuits. Of course, sympathetic nervous system is active in our fight or flight responses, or responses to threat or challenge or stress, and other kinds of stimulation or arousal. The parasympathetic nervous system, by contrast, expresses itself in what we could call the rest and digest response. There's fight or flight and rest and digest. And this is associated with the function of the vagus nerve itself. And we're going to address what diaphragmatic breathing means and some simple ideas for how to approach it, or awareness of the kinds of tension in the body that get in the way of diaphragmatic breath, and also how to recognize patterns in which the person is not breathing diaphragmatically for various reasons. Stress, I think, possibly could bring on hiccups for the same reason, interestingly. I'm going to move on from that. So we will be getting to those aspects of diaphragmatic breath. I wanted to point out the responses from these two aspects, or these two circuits of the nervous system. The spinal nerves are the nerves of the circuit of the sympathetic chain. And when those are activated, it brings about these typical responses in the body. And I'm pointing this out because it's going to be useful later on for recognizing when we've made the shift from sympathetic to parasympathetic, or have gone more deeply into a sympathetic response. Typical responses in the sympathetic chain are the pupils, of course, dilate to take in light more. The tear ducts, the lacrimal, the salivary glands slow down. So if you're nervous giving a speech publicly, your mouth goes dry, your eyes seem to dry up. The lungs, of course, open up the pathways for deeper breath in anticipation of needing more breath, more oxygen. The heartbeat, of course, speeds up. The liver releases glucose, sugar, into the system for extra energy. The stomach and the whole digestive system becomes limited in its function. The circulation is diverted away from that in order to concentrate on immediate needs. So people have experiences of butterflies in the stomach because of the change in circulation to the gut, so on and so forth. Of course, the adrenals are affected, and also the bladder relaxes to inhibit urination, because it's not very helpful if, while being chased by a tiger, you have to stop and pee. So basically, the non-immediate vital functions get shut down in favor of the most urgent functions that we need to draw upon in a case of stress or threat. The cranial nerves, on the other hand, again, are devoted mostly to a sense of what's going on in the body, but they also in turn transmit the response, which brings about a shift in these vital functions back to the more normal rest and digest situation. So the pupils of the eyes contract back to their normal function. The salivary glands, the tear ducts, restore their normal function so that you salivate once again, the eyes become more moist. And we'll see how the pathways of the lungs are toned for more efficient respiration instead of opening up wide for the breath. The heart slows down, and we'll see this is related to heart rate variability. The heart rate not only slows down, but also becomes much more adaptable from moment to moment. And so the rate itself changes, especially between inhalation and exhalation. And once again, the vital functions of digestion, the stomach are restored, circulation is restored to that. And so everything starts to work as it's meant to, once again. So the cranial nerves facilitate rest and the normal function of the digestive system and the breath. So they're restorative in the sense of bringing back this rest and digest function. Plus, they enable the senses that we use in interacting with our environment, especially interacting with other people. And so this aspect of the nervous system facilitates and promotes social behavior, and that openness to and availability to social interaction is a prime indicator of whether the person is settled into that circuit of their nervous system or not. I'm sure you can tell in working with patients, there are times in which they're really with you, and there are times that they're not. They're somewhere off inside somewhere else. That's an indication that they're not in that parasympathetic state. Now, Porges also introduced the idea of what he calls the vagal brake, which is the capacity or the effect of the activity of the vagus nerve to inhibit or slow down or put a brake on this sympathetic activity. You can recognize you're in a reactive state and consciously put a brake on that or slow it down. The sympathetic chain basically puts certain operations of the body on hold. The parasympathetic circuit opens up or reestablishes those functions, often as simple as telling the person to pause and take a deep breath. I mean, we kind of intuitively know this. The sympathetic response is meant to be temporary and used in abnormal situations. The paradox of this is you can flip into the sympathetic response in an instant. It takes much longer to restore parasympathetic activity, and our learned ability to participate in restoring parasympathetic activity actually can be measured in different ways. And what we'll call the heart rate variability as one primary measure for a person's ability to return back to that state. But that ability of the parasympathetic system can be overridden or blocked by a sense of danger or urgency. And that's where emotional issues get in the way of this, what's meant to be a natural response. Trying to get my clicker to work once again. There we go. So to get into those terms, there are signs of vagal health. A marker of healthy vagal response or healthy response of the vagus nerve is this overall flexibility and adaptability in responding from moment to moment to cues from the environment, the ability to turn the temperature down quickly if necessary, especially to maintain homeostasis in the body, kind of equilibrium by which we renew and regenerate. As I mentioned, heart rate variability is one key sign of this ability, and it's defined as the naturally occurring changes in the beat-to-beat rhythm of the heart, indicative of the state of the autonomic nervous system. basically, when you breathe in, your heart rate increases a little bit. When you breathe out, it slows down. This is also a sign of diaphragmatic breath because the heart essentially sits on top of the diaphragm. When you breathe in, the diaphragm contracts and moves downwards and creates a vacuum in the chest cavity, of course, and that vacuum draws air into the lungs. And in creating that vacuum in the chest cavity, it also draws blood more easily to the heart. There's more of a flow of blood to the heart. And so the heart rate increases slightly to accommodate that greater flow of blood, pumping it back out to the body. So it becomes a little bit more active. On the exhalation, the diaphragm, of course, releases upwards to push the breath out of the lungs. And by the same token, that little lift of the heart actually facilitates the blood flow through the arteries to the rest of the body. So basically, the heart relaxes as it gets help, and it doesn't have to work so hard to pump the blood. So it's very natural. The diaphragm facilitates circulation, and that variability, the higher heart rate on the inhalation, the longer, slower heart rate on the exhalation, is a sign that you're breathing diaphragmatically, which can be a little bit unsettling to people who aren't used to it. As a yoga teacher, when I teach diaphragmatic breath in a simple way, people are more conscious of their heartbeat as they relax and focus on it, and they start to perceive the speed up and slow down of the heart. And this, by the way, is different from palpitations, which is kind of a irregular heartbeat, like ba-thump, 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 ba-thump. And instead, it's like thump, 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 thump. It freaks people out to feel that, but it's also an indication that they're now breathing diaphragmatically, which is something that they weren't necessarily doing before. So a lower heart rate variability can also be a sign of less use of the diaphragm and more use of the chest. A growing body of scientific studies shows a correlation between a low heart rate variability and various psychological or psychiatric problems. It's related, this low variability is related to emotional states, especially negative ones, been found to decrease under conditions of acute time pressure or sustained acute time pressure in work environments, post-traumatic stress, emotional strain, and elevated states of anxiety. Individuals with a greater frequency and duration of daily worry are found to have a lower heart rate variability. It's related to a lack of ability to concentrate, to motor inhibition, muscles aren't working properly, and both of these are symptoms commonly found in children with ADHD. And there's also a link to post-traumatic stress disorder, and links or correlations found to reduced longevity or reduced life expectancy. And the reference for that is given from Rosenberg's book there at the bottom. And yes, different modes of biofeedback are used to measure heart rate variability. And this also makes the person more conscious in that feedback loop so they can actually practice diaphragmatic breath and experience the response of the slowing down of the heart on the exhalation, kind of reaffirming to the body that this is the healthier pattern of the breath. So they get used to it, and then they can return to that awareness, that biofeedback, even paying attention to their own pulse with the breath. And of course, blood pressure is also an indication of that, but that's not something people necessarily measure for themselves. So there are means of direct influence on vagal self-regulation. The most direct influence we can exert, as we've been suggesting so far, is through the breath, learning diaphragmatic breathing, inhibiting other patterns that overuse secondary muscles. We'll talk a little bit more about that. Heart rate variability can also be increased through movement disciplines. Certainly, through practice of yoga, other forms of exercise, anything, especially going back and forth between higher intensity actions and lower intensity periods of rests. The whole HIIT train is based upon that, though it's a more extreme form of exercise. But that movement between heightened activity and rest promotes this heart rate variability. And with that, the whole cycle of getting into diaphragmatic breath. There are, interestingly, therapies for stimulating the vagus nerve with interesting results. Dr. Kevin Tracy, this is something Rosenberg talks about, is a neurosurgeon who's used bioelectrics, implanting a small device under the skin to stimulate or send impulses to the vagus nerve. And this has been shown to regulate the body's inflammatory response. So he's been clinically successful in treating rheumatoid arthritis patients through this. And he also has seen some success with Crohn's disease patients, and also sees promise for the future in things such as Alzheimer's, cancer, diabetes, hypertension, and I think, again, a lot of the conditions that involve the body's inflammatory response, whether in response to infection or other things. So there's a lot of promising applications, and that's speaking in terms of direct stimulation of the nerve. We're looking at more indirect means here in terms of how, especially misalignments or overuse of muscles in the body, can inhibit a proper vagal response, and what we can do to correct that. The larger picture, in conjunction with that, is the most important aspect of working with the vagus nerve is to facilitate body awareness, the ability to look within and sense the body. Many people live in their stories, their emotional stories, and they're disconnected from the body out of which these stories emerge based upon the body's experience and past. And so we forget the source of our stories. And by going back to being in the body, inhabiting the body, we go back to the root of those stories and are also able to more consciously deal with the responses that come out of those stories. So awareness of the body helps us to avoid getting carried away by emotions that lead to faulty perception of danger, this faulty neuroception. And the very disconnect from the body just tends to perpetuate this faulty neuroception. So it is checking into whether we feel safe inside or not. If we don't, where is that feeling of a lack of safety coming from? And we're looking to reestablish, at least within, that sense of security and foundation. So the polyvagal theory kind of builds upon or elaborates on this basic model of the autonomic nervous system that so far we've just been setting out in terms of sympathetic and parasympathetic. And what Porges is suggesting is there are three distinct pathways or circuits of the system, the autonomic nervous system, each of which work in service of balancing our competing needs of being social on the one hand, normal function, and survival on the other hand, responding to threats to life or threats to survival. As we've been saying, vagus nerve is a major component of the parasympathetic branch. And Porges is suggesting that even though we speak of it as the vagus nerve, as if it's one nerve, it's actually a family of neural pathways with distinct circuits to it. So he's saying there are actually two branches of the vagus nerve, or two separate branches. And he's going to define them in terms of ventral and dorsal. The ventral referring to what's actually the front of the brainstem. Ventral means the front or the stomach. These are fibers that originate at the front of the brainstem. The dorsal aspect, or the dorsal circuit, has its fibers originating at the backside of the brainstem. So it's illustrated here in kind of a rough illustration. If you follow the gold or the yellow pathways, they go up to the front aspect. The purple ones reach back to the back. And the dorsal we can think of as the more primitive, or actually the most primitive aspect of the brain, sort of our lizard brain, whereas the ventral aspect is our most highly evolved aspect, the kind of mammal aspect of our brain. So these originate at different locations in the brainstem. Porges argues there's no direct anatomical or functional connection between the two. They're separate and distinct entities. This is where some of the controversy about the theory comes in terms of these suppositions about the very nature or constituency of these nerves themselves. There's argument on that level. But Porges is recognizing essentially this difference in function, which is recognizable in behavior and emotional responses. So within this family of the vagus nerve, there are two distinct circuits or two distinct branches which evoke very different physiological states in the body, affecting organs, as well as very different distinguishable emotional responses and promote different behaviors. And that's what gives us a more varied picture of the nervous system. So there are three circuits. The ventral, what we call the ventral branch, manifests in positive states of relaxation, social engagement, positive emotions of joy, satisfaction, love, which expresses itself in positive social activities with friends and loved ones. And this isn't about being extroverted versus introverted. That's a different issue in how you respond in your life to that state of the nervous system. Overall, ventral activity dominates in a situation of feeling safe in the body, safe in our environment, and promotes a continued feeling of safety. Spinal sympathetic chain, we can think of as mobilization with fear, which arises, of course, when we don't feel safe, and especially relates to emotions of anger or fear. And this third aspect, which is the kind of new dimension added in, the dorsal branch of the vagus nerve, manifests in slow down, shut down, depressive behavior when a person is faced with seemingly inevitable mortal danger or insurmountable challenges. And it often, or it can come at the end of a whole series of experiences that have just exhausted the nervous system. I was reading one therapist who was encouraging people to write down, remember experiences of being in these different states, and especially with this dorsal state. This one patient wrote down one day they were working in the kitchen and they knocked a flower pot off the table. The flower pot fell down and smashed, and it was valuable to her because it was kind of had sentimental value. And when the pot smashed, she just sat down on the couch like, I can't do this anymore. And she just totally shut down for a while, a complete sort of response of giving up, which was totally out of proportion to simply smashing a flower pot. But that was at the end of accumulation of a whole series of stresses that just led to that essential shutdown. Rosenberg points out there are actually two hybrid states of this, which we experience both in feelings of intimacy, which is a kind of mixture of both the ventral and the dorsal. In a sense, there's a slow down and snuggle phase, which is part of the slowdown of the dorsal response, but it's in the context of a feeling of safety with another person. So we slow down our physical activity. We're not mobilized, but it's a combination between the two. In states when we're heightened, such as in sports or competition, there is the aspect of friendly competition, which is a blend of both sympathetic and parasympathetic ventral social response in the context of having rules. When there are rules present, everybody feels safe, and so you can compete to the maximum, being stimulated on a sympathetic level, but at the same time not flipping into the kind of sympathetic emotional response, which involves anger and even fear. You can certainly see that come up in a game when somebody feels the rules have been broken. There's a quick move from simple competition to actual anger and aggression because that safety has been compromised. But overall, if the context brings safety, then you can have hybrid forms of these responses. Now, it's worth looking at the problem of chronic activation of the dorsal branch. This is characterized by lack of physical energy, low blood pressure. I think somebody needs to mute at the moment. I'll see if I can facilitate that. I can't get my mouse to work for that. Chronic activation of the dorsal branch, lack of physical energy, low blood pressure, fainting, breathing difficulties stemming from constriction of the airways, such as in COPD, chronic obstructive pulmonary disease, and also chronic generalized muscle and joint pain, fibromyalgia, chronic fatigue. All of these are signs of this dorsal activation. There we go. Let's see if I can mute. There we go. Good. I myself should not be muted. Let me know if you can't hear me. Chronic dorsal activity is also a factor in depressive behavior, social isolation, feelings of helplessness, hopelessness, apathy, lack of empathy, sadness, grief, and some cases of post-traumatic stress disorder. Again, these are listed by Rosenberg. I wanted to, in getting into this, look at the problem of breathing pattern disorders and how this manifests. An interesting aspect of proper function of the ventral branch of the vagus nerve is how it affects lung function on almost a cellular level. What it does, as opposed to sympathetic activity where the lungs just kind of open up to maximize the breath, the ventral branch stimulates a rhythmic action of the bronchioles, the tubes that lead out to the sacs of the alveoli. And it stimulates the bronchioles to slightly open on inhalation to allow the breath in, and on the exhalation, they slightly constrict to slow the exhalation from the lungs, and this facilitates the most efficient extraction of oxygen and an optimal balance of oxygen and carbon dioxide. So it kind of goes with the longer extended exhalation that goes with the slight toning of the airways that takes place. Breathing pattern disorders, and there's a book by Leon Chaitow that I cite here that goes into this in quite a bit of detail from different therapists writing different articles surrounding this. Breathing pattern disorders tend to center around problems of what we often call hyperventilation, or a better term for it is actually overbreathing, where the meaning of the term is that overbreathing is defined simply as breathing too much for the body's needs, or breathing or the movement of the breath in excess of the body's needs at the moment. And that can manifest in different patterns. So it's not necessarily hyperventilation in the sense of a panicked sort of puppy breath, like that sort of breath. It could be simply a kind of collapsed sighing breath, both of which, and all forms of which, tend to expel carbon dioxide too quickly and too much in relationship to what's going on in the body at the time. Hyperventilation itself, that kind of panic breathing, is defined by the amount of air being exchanged rather than the rate. We're looking at what happens to blood chemistry, again, essentially from expelling too much carbon dioxide. The chemistry I'll try to define simply is in terms of the blood cells, of course, go to the lungs to pick up oxygen and let go of carbon dioxide. And with that exchange, the lungs expel carbon dioxide. And their efficiency in doing that depends upon the pH of the blood, which it varies according to the level of carbon dioxide present. What happens is when a person overbreathes and expels too much carbon dioxide, the blood becomes more alkaline. And this leads to what's called the Bohr effect, which means the cells are carrying oxygen to the tissues, but because of the alkalinity of the blood cells cannot let go of the oxygen molecule. And so they return back to the heart once again in this cycle. So even though the blood is essentially highly oxygenated, the oxygen is not getting to the tissues. And so the body feels oxygen starved, even though the blood literally is not. Of course, the response is you start to breathe more quickly, and people have the experience, I can't get enough breath, I can't get enough breath. They further overbreathe, and it becomes this vicious cycle in which it becomes worse and worse and worse. And of course, commonly you give a person a paper bag to breathe into, they rebreathe the carbon dioxide instead of expelling so much of it, and then they start to return to a calmer state. And there's a whole galaxy of symptoms that arises from this sort of syndrome, beyond just muscle pain that comes from overuse of muscles. It includes foggy brain symptoms, increased sensitivity to pain, light, sound, stiffness in the body. Allergies become more pronounced. And for women in the progesterone phase of their menstrual cycle, all of these symptoms are actually heightened. Allergies become worse, bodily pain becomes worse, foggy brain, digestive problems, bloating, so on and so forth. All of this becomes increased. And the response to this overall breathing pattern disorder, the consensus for the most productive response is essentially, of course, that the breath needs to be slowed down, but especially in order to increase the person's tolerance for carbon dioxide, researchers recommend emphasizing extending the exhalation and becoming comfortable with a pause at the end of the exhalation before the next breath in. Because the dynamic, somebody's saying they're having trouble with the connection. I just want to verify you guys can hear the audio. Just let me know in the chat box if that's going okay. Yeah, okay, good. The problem of this syndrome is a person develops a hypersensitivity to carbon dioxide. In the Buteyko method of breathing, they test this by having a person take a few normal breaths and then exhale and pause and see how long they can remain in that pause, holding the breath out before they feel an urgent need to breathe in once again. If they can't tolerate holding the breath in that way for more than 10 to 12 seconds, it's a sign of hypersensitivity to carbon dioxide in the blood. And so they need to start to practice breathing patterns, practicing what in the Buteyko method they call the control pause. In yoga, we call it breath retention, to be able to hold the breath comfortably for longer periods of time, going beyond 10 to 12 seconds. And that kind of resets the nervous system to be more comfortable with those oxygen and carbon dioxide levels in the blood. And that's facilitated through that cranial nerve number 9. I wanted to point out, if I can get this to work, I did include a graph from the book, Leon Chaitau's book, that kind of shows the cycle in a bit more detail, both in terms of our emotional response, but also what's happening on a biochemical level that I just described. An interesting side effect, what kind of leaps out at me, is with that hypocapnia or alkalinity of the blood, the body actually starts to lose calcium through the urine, which has a couple of effects. First of all, muscles and nerves tend to function more poorly, and nerves can become more sensitive. And of course, there may be a long-term effect upon the health and strength of bones connected to osteoporosis. All of that's looking at the long-term consequences of this hypocapnia. So that's something you can look at in a little bit more detail if you want to, but it's kind of the cycle that I was just describing. We can recognize different common breath holding patterns. I wanted to touch upon them briefly. Forms of chest breathing that take on different patterns. One is called reverse breathing, where the person tends to use the chest muscles more for the inhalation, the inspiration, rather than the diaphragm. So the person breathes in with the chest, often uses the shoulders with that, and that lift and opening of the chest tends to pull the belly in. And when the person breathes out, the chest releases and collapses, and that drop of the chest tends to push the belly out once again. And the problem posed by this pattern is very often in trying to teach diaphragmatic breathing, we try to make the person aware of the stomach, and people are told to breathe into the belly or breathe into the stomach. I'm not particularly a fan of that because diaphragmatic breath is actually more three-dimensional, involving the lower ribs at the side and at the back. But in any case, that's completely counterintuitive to the reverse breather, because his experience is with the in-breath, the belly comes in, with the out-breath, the belly goes out. And when you tell the person to breathe into the belly, making the belly go out, they tend to collapse the chest further and feel stuck in the breath And it's also counterintuitive to firm the belly with the out breath. So you actually have to start to stabilize or neutralize the use of the chest, perhaps taking a slight breath in to open the chest, and while keeping the chest, the rib cage, neutral, start to feel the movement of the belly at the front as well as the side ribs, and even feeling at the back. Feel that movement as a diaphragmatic breath, reducing the movement of the chest while increasing the movement of the diaphragm. And there are different modalities for doing that, different tricks for doing it, but that's the essence of how you do it. There's also paradoxical forms of chest breathing, and this is more where people tend to constantly hold the abdominal muscles tight, whether for emotional reasons or just for the sake of a fit appearance. People tend to hold the belly in very strongly and limit the movement of the breath to the chest. Then you find an even more aggressive use of the shoulders, the chest, and even the neck muscles with the inhalation. And also the exhalation is not complete because there's a limit to how much both the breath can come in and how much the breath can go out, because the chest can only go so far while holding the abdomen tight. In order to have a good inhalation, you actually need a complete exhalation, and that abdominal tightness gets in the way of the completeness of the exhalation, which is the precursor to the next inhalation. So once again, tension held in the neck or the shoulders. If the person's practicing breathing, you can often see them activate the neck, pushing the head back or tightening the shoulders. You can also observe a lack of movement in the abdomen on both the in-breath and the out-breath, and encourage a softening of the belly as well as a relaxation of the shoulders. The opposite pattern, in a sense, is collapsed breathing, where the person is still using the chest to breathe, but this is a kind of sighing breath where they breathe in like this, but breathe out with that kind of collapse. And the rib cage collapses down on the diaphragm. So with the movement of the chest, there's less possibility for movement of the diaphragm on the inhalation because the belly has lost all of its tone. The diaphragm can actually get stuck under the ribs or go into a kind of spasm from the collapse of the rib cage on the diaphragm. And again, the person tends to overuse the upper body and the neck in that process. There's no space made in the upper body, so there's no room for the diaphragm itself to move. And this is connected with posture, a forward head posture, slump shoulder posture, a slump in the chair sort of posture, all of which is described on the right-hand side in the notes. We're going to get back to that in a moment. A related pattern is something that Donna Fari, who's a yoga teacher that specializes in pranayama, calls frozen breathing, in which the entire body is held tight or resistant to movement with the breath. So there's very little evidence of movement with either the inhalation or the exhalation. Here I've got it described in terms of vayus, which is more of a yogic terminology. The yogic breathing techniques for improving this balance that facilitate diaphragmatic breath are essentially called Ujjayi breathing. And this is associated with a spacious sound at the back of the throat. I think it's often mistaught in yoga because some yoga teachers tell the person to tone the throat or tone the glottis so you can hear the breath like from across the room with more of that kind of sense, which is actually a constriction that sends the wrong message to the nervous system that you're under stress. What happens in the Ujjayi breath is the throat configures itself to more of an ah sound, as if you're whispering the sound ah on the exhalation. I even have students say, okay, now verbalize ah. See what your throat does when you say ah. Now verbalize E and see what your throat does when you say E. Your throat constricts a little bit. So the breath is meant to be more like whispering the sound ah on the exhalation and also on the inhalation. And we do this through the nose when you do it silently. And you can connect to the feeling just by making students yawn. I say, it's easy to make people yawn. You do this. I say, now notice what's happening with your throat. When you yawn, the back of the throat lifts and blossoms. And that's actually controlled by one of the cranial nerves that run directly to that muscle. It's mentioned at the end of the notes, that causes that lift and opening of the uvula at the back, which both controls our gag reflex, our ability to swallow without the food going down the windpipe, and also modulates how the breath moves through the throat and the sinuses. So actually a sign of dysfunction in the ventral vagus nerve, and Rosenberg observes this. He says if you shine a flashlight in the person's throat with the mouth open and just have them say, in a percussive way, he looks at how much the uvula at the back of the throat reacts to that verbalization of If the uvula goes slightly to one side, it's a sign of dysfunction on the side towards which the uvula moves, because that muscle is not activating. So the vagus has two branches, and neck tension on one side can affect function of the vagus on one side of the throat. So if you're promoting this sort of ah breath, or directing that ah breath, especially directed through the nose, with that feeling of that whisper in the throat, which is kind of this cavernous quality to the breath, you're facilitating both diaphragmatic breath, because when you breathe through the mouth, you tend to use chest muscles, like is more chest breathing. Through the nose, because it slows down the breath, tends to be more diaphragmatic. And with the space at the back of the throat, again, you're connecting with the cranial nerves, with the flow of the breath through the nostrils and through that conscious flaring of the muscles at the back of the throat. So it tends to light up and open up all of these aspects. When that's thrown off, yeah, I think that can be connected to hiccups. But these are ways of facilitating with the breath that movement. Now, these forms of collapsed breathing, I think, can be very much connected to the dorsal branch of the vagus nerve, and are kind of signs of that collapse through the dorsal branch, because it describes breathing pattern dysfunctions that don't fit easily into our concept of the sympathetic nervous system, which is this heightened state of response. These breathing patterns signify more of a depressed state of the breathing response, which is also shows itself in muscle tone and this sort of collapsed breathing. So certainly we'd want to move out of this dorsal response into a ventral response. In the same way, we'd want to move from the hyperstimulated sympathetic response back into a dorsal response, which brings us to looking at further tools for readjustment in the nervous system beyond what I've said about the breath so far. And again, these features that I mentioned about the breath and the back of the throat, I've got more details at the end of the notes that you can look at, because I'm not entirely certain I'll be able to get to that without going too far over in the presentation, but I'll try to. Some tools for readjustment is based on the recognition physiologically that cervical misalignment of the first two vertebrae, C1 and C2, the atlas and the axis, imposes an effect upon the vagus nerve, especially ventral vagus function, as well as circulation to the brain, in a way that, again, with misalignment, it can reduce proper function. If you correct the misalignment, you can restore proper function and circulation. And a key to understanding this readjustment that does not involve doing a physical adjustment upon another person, or even going in and trying to fix your neck for yourself, a key recognition is that the muscles surrounding these vertebrae are highly sensitive to eye movements. And it's through the use of eye movements that you can facilitate a realignment or readjustment. And by the same token, because it's connected directly into the brainstem, which in turn provides a feedback function through the nerves to the muscles, Rosenberg points out that even with a readjustment, it only takes a single negative thought to impose a subconscious effect upon the muscles around the neck that can actually bring C1 and C2 out of alignment once again. So eye movements as well as thoughts have a profound effect upon vagal function. We're going to look at two approaches for a more indirect influence upon the vagus nerve by influencing the environment around which it functions. The first is to look at the connection between eye movements and muscular readjustments, particularly looking at what you see in the illustration there, which is the very small aperture through which the vagus nerve passes at the base of the skull just beneath the ear. When there are slight micro movements of the head in which both the skull and the cervical vertebrae impose upon that aperture, that's what puts pressure on the vagus nerve itself. So we're looking at a release of tension and misalignment to reset the position of the cranium and the vertebrae in order to restore proper function. That's going to be facilitated first through eye movements, and second, also notice how occipital nerves, which pass through the suboccipitals into the scalp, are also influenced by fascial tension in the scalp as well as in the suboccipital muscles. So a certain degree of fascial release in the scalp combined with muscular release around the cervical vertebrae can also help to restore proper vagal function by a simple stimulation of that. And again, this happens in a very passive way, in a very simple way that people can do for themselves once they learned it. So we want to look at resetting the system. This has to do with understanding the function of the suboccipital muscles. There are 10 of them at the base of the skull that connect the actions of the head to C1 and C2. 8 of these are suboccipital at the back of the vertebrae, and additional 2 are at the front. And in these animations, you can see we use suboccipital to tilt the head up and down. And you can see particularly in the animation when the head tilts up, the cranium actually slides forward a little bit on the atlas, as well as the vertebrae itself tilting. We can get stuck in that pattern with the forward head position. The more the head is forward of the center of the body, the more the head tilts to keep the eyes looking forward. And so you're in a chronic state of activation of those suboccipitals. The suboccipitals are also active in side tilting of the head. And if posturally our chest is shifted to one side, the body compensates for it for tilting the head to keep the eyes level. And in that lateral misalignment of the body, you can develop chronic tightness on one side of the neck. Also involved in habits such as using the right hand for controlling the mouse on a computer, the tilt to the head that comes with that can cause that tightness. And also eye dominance. We tend to be more dominant with one eye than the other. So when you're dominant through the right eye, the head tends to turn and tilt a little bit as if dominating or emphasizing the eye through which you're looking, which again increases tension in the suboccipitals at the side. Yeah, if you have to leave, do look back at the recording this. And the third suboccipital, or the third aspect of the suboccipitals, has to do with rotation of the head, which you can see here. And when the head rotates in a symmetrical way on top of the spine, there's a sense in which the spine kind of lengthens upwards, whereas when there's neck tension, when the person turns the head, there's more of a compression downwards or a crowding of the nerves around the base of the head. This illustration is showing a little bit more closely on the right how the vagus nerve exits from the spine. There's also a vertebral artery that goes through the same pathway that feeds the frontal lobes of the brain, as well as an accessory nerve that feeds out to the trapezius and the function of the shoulder muscle. Tension in the suboccipitals in general can affect the function of these three: vagus, circulation, as well as the accessory nerve to the trapezius, and can affect other nerves leading to tension headaches, and so on and so forth. I wanted to mention for a moment about the vertebral artery, because again, that sends circulation to the frontal lobes of the brain, which are more involved in, shall we say, social activities. The constriction of that circulation has a sort of evolutionary survival value, because our first reaction in the face of stress or threat is to do this with the neck. We crouch a little bit in the psoas. We also crouch in the neck, pulling the head down on the spine. The effect of that is that it limits the circulation to the frontal lobes of the brain and redirects the circulation to other aspects of the brain that are functions that have to do with self-protection, aggressive response, or especially this sort of dorsal shutdown response that the brain has, all of which is connected to faulty neuroception. If you have a faulty perception of danger, or you're triggered by a traumatic memory, you can flip directly into that physiological response, which affects brain function. So Rosenberg mentions a study of brain scans measuring circulation of the brain with women in post-traumatic stress disorder, and they showed how even at the hearing of a retelling of traumatic events, the blood flow in the brain changed or was diverted from the frontal lobe. So they're able to show on the level of that study how dramatic that shift takes place. And I wanted to repeat, just as we get into working with this very simple resetting exercise, some of the features that you look for that signal a response back into or a shift back into a ventral vagal response. It can be a watering of the mouth, salivation, a desire to swallow. Some students have even reported that their eyes tear up a little bit and they think they're about to cry, but it's actually a reinvigoration of the lacrimal glands. So it can be a swallow, salivation, a movement of the lips, like a smacking of the lips, also a change in lung function, kind of a yawn, which signals movement into diaphragmatic response, or a sigh in a particular way where the in-breath deepens with the sigh, kind of like you take a little extra breath in before breathing out. That's a reinvigoration of the diaphragmatic response. And also, of course, a feeling of a change in the heartbeat. It slows down, particularly with an extended exhalation, or just a feeling of an internal shift within the body. Now, to understand how this functions is just to be a little bit aware of how responsive the suboccipitals are to eye movements. One example is to have, or to try for yourself, or have a student place their fingertips at the base of the head. You're touching larger muscles on top, but underneath that are the suboccipitals. The head remains neutral. You don't let the head move, but turn your eyes way to the left, to the right, up, down, even make big circles with the eyes. And you may be able to feel small responses in the muscles of the base of the head, as if the head wants to turn to follow the actions of the eyes. That's essentially the job of the suboccipitals, which is to facilitate getting the head to move and follow the actions of the eyes. The eyes look right, the head moves in that direction, so on and so forth. So even when you neutralize the movement of the head, a shift in the movement of the eyes changes the tone of the muscles, the suboccipitals, which changes their pull upon those first two vertebrae. So what Rosenberg calls the basic exercise is very simple. I'll show the first aspect of it first and kind of describe it, and then we'll try it out. It's best done reclining, and you'll be interlacing your fingers and putting your hands at the back of your head with the index fingers basically across the base of the skull. And when you recline, that allows your head to relax back into your hands. So you're putting a little bit of a calming pressure on the fascia of the scalp. So that relaxation aspect softens the scalp, and actually opens up the pathways for the activity of the occipital nerves. That's why it's more effective lying down than sitting up. You don't get the same relaxation response. And it's nice to have the head supported by blankets. And if the elbows or the shoulders are stiff, you can support the elbows with blankets so you don't feel tight from the elbows sitting back. I'll describe this first. I just want to describe it, and then we'll do it because we want to do a little check-in before we do it. The actual action that we practice is lying back with the head supported without allowing the head to move. You'll simply turn your eyes to one side as much as you can without it being uncomfortable, and hold the eyes in that position for a good 30 to 60 seconds, or until you feel one of the subtle shifts that I described: a little salivation, desire to swallow, a smacking of the lips, a yawn, a change in heartbeat. Once you feel that shift, you bring the eyes back to center, and then practice this to the other side, recognizing that we may have more tension in the suboccipitals on one side than the other. So as a lead up to trying this, first I'd like you to sit upright. If possible, have a space prepared where you'd be able to lie down, because it's more effective in that way. But first we'll just check into the movement of the head, because that gives a further confirmation of relaxation of the muscles. While sitting upright, just turn your head to one side, let's say to the right. See how far the neck turns, head to center, go to the other side. Just go side to side to check in on the fluidity with which your head turns, going slowly, and also where you feel resistance in the muscles. Of course, when you turn your head to one side, at some point the muscles resist the head turning farther. Otherwise, you've got a different neck problem going on. So we're just checking in to see how that feels, because we're going to repeat that check-in after doing the neck exercise. So having done that, lie back, if possible, or in some way that allows the head to be supported. If you're sitting upright in a chair that has a headrest, you can relax, tilt the chair back, and rest your head against that head support with the base of the head in the palms of the hands. And let your head and the neck relax into the hands so you reduce the activity of the larger neck muscles. Now, neutralizing the head in that position, turn your eyes, let's say, way to the right, and hold the eyes in that position. Later on, you can experiment with looking to the right and slightly looking up or looking down, but basically hold the eyes in that position, breathing normally for a good 30 to 60 seconds, or until you feel a subtle shift inside. The eyes might moisten, you might feel salivation in the mouth or swallow, or you might feel a subtle shift in the breathing, the heartbeat. If and when you feel that shift, or after about 60 seconds or so, bring your eyes back to center, and then turn your eyes to the second side, to the left. Again, keeping the head, the neck passive. Hold the eyes in that position. Again, being open to a subtle shift. And the shift may be more tangible or dramatic on one side than the other. If and when you feel that shift, or after 60 seconds or so, bring your eyes back to center. And then take a moment to come upright, and then check in once again, turning the head to one side and to the other, and see if there's a shift in the mobility of your neck. And also perceive if there's a subtle inward shift or calming shift of the nervous system itself. You're simply using the eye movements to affect the activity of the muscles around the suboccipitals. And all those signs that I pointed out of an internal shift are just a sign of shifting back into a place in which you begin to restore that ventral vagus activity. So it's a simple little exercise that a person can do to kind of bring themselves into a state in which they might proceed with diaphragmatic activity or proceed with what they're doing next on a therapeutic level. There's an additional indirect effect, which is through the fascia itself of the scalp. Holding the head in the palm of the hands was one effect upon the scalp. This one is kind of a very simple fascial release technique. It can be done in two ways. And it's not a muscle massage. You're not going in there and rubbing on muscles to get them to release. Rather, you're kind of melting into the connective tissue of the skin, getting that to release, which in turn has an effect upon innervation or flow through the occipital nerves, as well as a subtle effect upon the suboccipitals themselves. The location is shown here, where you're going to place your finger or your thumb is just underneath the skull, which is the pathway of the occipital nerves that are shown here in this illustration. And here I show it's right at the base of the hairline. If you've got a ponytail, you might have to move it. You can use your thumb, you can use your index finger, both of which are more sensitive, whichever works for you. And the idea is, we'll do it one side at a time. Place the finger on the skin without pressing too hard, and you move the finger side to side just to check into the sort of slidability of the skin on top of the muscle. The skin gently glides without pressing too hard on the muscle. You slide to the left towards the spine, let it come back to neutral, then go to the right. And what you're perceiving is which direction you feel a little bit more resistance in the skin to that sliding. Obviously, you go a long distance, there's resistance to both sides, but you may find the skin moves more easily in one direction and not so easily in the other. Once you've determined one direction has more resistance, you slide the skin in that direction until you just begin to feel that resistance, not pushing further. You just pause there and stay with it, holding that position. Let the finger kind of melt into the skin, and you may feel gradually a little bit of a melting or reduction of that resistance. The skin melts underneath. And when you feel that shift, you can go back to testing the slidability, going side to side. And you may feel in the direction where you felt resistance before, there's a little bit less resistance. Once you feel that shift, you can release your hand down and notice the difference in sensations, both at the base of the head and just through that side of the face overall. Often there's a sense of warmth, like increased circulation, a sense of more ease or softness in the muscles of the skin. Just that side feels different. Can do the same on the second side, going back and forth. And paradoxically, on the other side, you might feel the resistance in a direction opposite to the first side. That just has to do with the fascia around the muscles on the two sides of the suboccipitals. But again, you go side to side, determine the side where there's more resistance, go to that side and pause, and just wait for that to relax and melt a little bit. And once you feel that melting, check out if there's a change in that slidability, and also release the hand down and feel a change in the sensations on that side. It can even radiate forward to a softness in the eyes and a softness in the face, and can be helpful in cases of even low-level migraines, where the definition of a migraine is basically means on one side. A migraine headache can be related to tension in the suboccipitals, which can be fascial as well. But this is also a kind of resetting or a softening technique. And there's a little bit of an elaboration on this, where you can go with two fingers. Here you've got one finger at the base of the skull, the other finger just above that on the skin. And here you slide the skin in opposite directions, fingers toward each other, away from each other, and find on the one side, is it more resistance towards each other or away from each other? You just find the direction in which you feel a resistance. Once again, pause there, let that melt and relax. Test the slidability once again. And then when you release the fingers down, see if there's even more of a change on that side, and you can do on the opposite side. Again, it often works in opposites. So that's an additional fascial release technique, which can also be helpful in terms of promoting circulation, neural activity, release of muscular tension, all of which works in creating that readjustment. And yeah, when there's a popping in the neck, that can be a sign of a shift. First of all, the popping is in the small fluid-filled sacs between the bones of the vertebrae, the synovial fluid, which are kind of the sort of lubrication for the movement of the neck. If the head is chronically stuck with a little bit of a tilt with tightness, especially in the intertransversarii muscles, those sacs get a little bit dehydrated, essentially, and the cartilage gets a little bit sticky and the bones get stuck in that position. When there's a release in the fascia as well as the suboccipitals, facilitating that shift through the suboccipitals, you might get a little pop, which is a tiny sign of a readjustment. And yeah, it does prove to be helpful in reducing symptoms of a little bit of a headache. And what advice do you have for breathing for those experiencing mild to moderate COVID symptoms that do not experience the severe complications of breathing? I think basically everything I've mentioned so far tends to address that. And also with mild symptoms, the kind of pressure in the chest tends to perpetuate the chest breathing, which sets up this cycle, this kind of panic cycle. And so to start to study the action of the chest and emphasizing the breath with the belly through the diaphragm can be helpful with that. That basically completes what I wanted to offer here. I just reemphasize the lightness of this touch, where it's not a form of massage or a fascial release. And then what I discussed before in terms of signs of vagal states are just further illustrated here. The action in the back of the throat, especially the lifting of the palate, all of that I described earlier, and it's just once again illustrated at this point. So you can certainly refer to the notes to look into that a bit further, but I'm stopping the notes themselves and stopping the sharing. So that kind of completes the time for the presentation itself, but I'm happy to take questions here. And out of the books that I referenced, I think the one by Stanley Rosenberg is the first one I'd direct you to. It's cited a number of times in the notes. If you're pretty anatomy savvy, then you'll be able to take in the first chapter. Otherwise, I kind of recommend skipping to the second chapter, going from there, and then you can go back to the first chapter, and it's a little bit more clear exactly what he's talking about. Yeah, the Rosenberg book is quite good. Of course, Stanley Porges himself has books about the theory that he's setting forth, both simplified versions and more elaborate versions. That's a tougher read, and it gives you less practical applications. So the Rosenberg book has more direct practical applications. The other mentions I gave, I'm slipping on her name at the moment, at the very beginning. Yeah, the Deb Dana with Polyvagal exercises for safety and connection. That's working a little bit more from the aspect of cognitive therapy, or working with a patient interactively on an emotional level, and is a little bit less about these practical techniques. So the center of what I've given you here comes largely from Rosenberg's book. And if you want to explore breathing pattern disorders further, then Leon Chetow's book is a good resource, where he goes into different modalities, both yoga as well as different breathing techniques, and even goes into the contribution of other modalities like Pilates and other movement forms of therapy like that. Yeah, and
Thank you, Doug. I just wanted to jump in really quick just to let everyone know that that survey link, I'm kind of posting it repeatedly in the chat since people are continuing to ask questions. But those of you who would like CEUs, please complete that survey link, and I'll also send it out via email along with the recording. So thank you all for being here, and Doug, you can go ahead and continue to questions.
Yeah. So if anybody has any additional questions, if you want to unmute yourself and ask them verbally, you're welcome to do that, or just in the chat box. And if there are no questions, that's always a good sign too. It's a lot to take in.
Which book did you say after the Rosenberg one that you said like maybe not to read? There's not a lot of practical.
Yeah. Well, on the one hand, you'll find plenty of books with Stephen Porges himself going into more detail about the theory. The ones that I'm aware of tend to be highly technical and don't give that many practical exercises to do. I mentioned Deb Dana's book called Polyvagal Exercises for Safety and Connection as client-based practices. She tends to emphasize more contemplative exercises as far as verbalizing your states or journalizing your states. And so it's less physical exercises and more contemplative exercises in that sense. So it's not quite on the in the modality of what I've been talking about here, but certainly that gives you some good further resources for contemplation of the whole polyvagal approach and how it relates to what you do. So it's certainly a useful book to do. Yeah, as far as therapies for rapid eye movement therapy to work with trauma, I think that's connected to what I'm talking about, and also it's more specific to what they're trying to accomplish directly through that rapid eye movement therapy. I'm less familiar with it, so I'd say there's a connection, but that also probably involves or demands more direct one-on-one direction of the person how to do the therapy, how to do it. Whereas this one, once a person learns it, they can go back to practicing it and be fairly confident in doing it well. Yeah, how are you able to maintain diaphragmatic breathing? It's especially hard in doing these presentations because I'm sitting down and it becomes decreased. And actually what I pay attention to, which you can hear in my voice right now, when your voice gets a little bit more thin or strained or softer, is not quite as strong, it kind of gives you a sign that you're moving into using the chest for your speech instead of the diaphragm. So I remind myself to pause and drop into basically a deeper voice. You pay attention to dropping the vocal cords a little bit, sort of that yawning breath, and that's a sign that you've dropped the breath and your speech back into the diaphragm itself and release this sort of throat tension. So I'm aware of times in which I start to get into that constricted throat and remember to drop back down out of it. All of which relates to that sort of what in yogas we're calling that ujjayi breath, or that relaxation of the throat. Or kind of imagine you've got a bow tie on and you're dropping the bow tie down slightly. Yeah, as far as relationship to autism and ADHD, the chapter or Rosenberg's discussion will direct you to the best resources for that. What he's found in his practice as a cranial psychotherapist, especially working with children, is what he's noticed, and Porges has noticed too, that in children who are on the spectrum, there's a flattening of the base of the skull on one side, more often on the right side. And Rosenberg noticed a relationship between that flattening of the shape of the skull and tension held in the sternocleidomastoid muscle. And so his therapy is to work to release tension in the sternocleidomastoid muscle. And with that, the shape of the skull starts to readjust developmentally. But that's very suggestive as far as how muscular tension early in life can be related to the change in the shape of the skull, which in turn affects the function of the vagus nerve, which could be related to these symptoms of being on the spectrum. Porges himself has been doing workshops and presentations using sound therapy for treating autism. Again, related to dysfunction, I have a friend who's a yoga teacher and a therapist who took that workshop, and she said there were good indications that that sound therapy was very effective in cases of autism. For herself, she's not on the spectrum, and she found when she participated in that sound therapy, it really messed her up. And it took her a couple of days to actually recover from the effects of doing that sound therapy, which suggests that it's very powerful in working with people with autism, and there are kind of contraindications for people not on the spectrum because it could throw off their nervous system in different ways. So that's a beginning point for finding these resources, other resources for individuals, I'm not quite sure what IDD means. My brain's not functioning at that moment. I'm not aware of other resources offhand.
Intellectual and developmental disabilities.
Yeah, I'm not as aware of resources from that perspective. So, but I'm...
See, the techniques are wonderful, but as somebody that works with that population, I'm just wondering how we even get to the point where we can assist the people we serve with, just the idea of getting somebody on the floor with their arms up.
Yeah.
Some might be okay with it, but others not so much. Like that would just, I think, re-traumatize them.
Yeah, that's a good question. I think the essence of that technique is to get the neck and the scalp to relax. So any form of support for the scalp is going to be useful. So it doesn't necessarily require the use of the hands or being in that position. It could be on a slight recline with the head relaxed, so there's less tension in the neck. And of course, there could be triggers, I imagine, even in the eye movements for people that make it difficult. But any relaxed position that allows them to start to come into a relaxed breath, as well as practice the eye movements, are basically on the right track. And the obstacles that still come up, even in connection with doing that much, I'm guessing there are resources out there for that, but I haven't done that kind of work myself and haven't come in contact with resources that speak to that deeply. But I think there are ways of modifying what are described here which might actually work for these clients or these patients. I just don't have a lot of experience in doing it myself. But thanks for bringing that up, because again, that particular description of the practice is not always required. Yeah. Good. Any other questions around that?
Have there been any studies of incorporating music into these?
Yeah, I think that's on the side of the sort of sound therapy that Porges does, and I would imagine that there's a good amount of research out there connected to it, because certainly there's that connection through the ear, the auditory, and perhaps even the adjustment of the head that takes place when you're in the attitude of listening, especially when you're open to listening, and even within the context of yoga, working with the breath or meditation or relaxation, I kind of describe the movement as a movement into being in a position of listening rather than looking. Like in the context of meditation, people treat meditation as a kind of focusing or looking, as if they're focusing the mind in a way that can actually introduce neck tension from that effort to focus. Where again, I'm saying with the attitude that you're listening inside, listening to the breath, even listening to music, or listening to even the internal repetition of mantra, that attitude of listening brings about a different shift in the attitude of the neck and the tone of muscles around it. So I think that'd be a really interesting avenue to pursue, and I'm sure there's lots of different kinds of research out there surrounding that. None that I'm aware of at the moment, but I think it'd be really good to explore, and also a different approach. Yeah, the question, controlling the breathing and relaxing the body help counter the long-term effects in terms of lower life expectancy of low heart rate variability. I think it definitely can reverse those effects, because when you focus upon the breath and the diaphragmatic breath, it does bring about a fairly quick adjustment in heart rate variability, because the action of the heart is so closely tied to the action of the diaphragm. I think you can get good effects from focusing upon diaphragmatic breath. And again, you can find a lot of suggestions for accentuating diaphragmatic breath. Another good resource is Donna Farhi's book called The Breathing Book. I mentioned her name in the notes. Her book is called The Breathing Book. And so she has different modalities for being aware of diaphragmatic breath. A useful one I came across recently that's kind of helpful is to lie down, and actually in lying down with the knees bent, it can give a little traction to the hips, but actually pin the back, firm the abdominals so the mid part of the back kind of comes in contact with the floor. So you're kind of pinning the back to the floor, and then breathe in as if you're drawing the breath all the way down into your waist or your hips. And in doing that, you're much more aware of how the breath moves in the back body into the back part of the diaphragm, because one of the restrictions are muscles around the lower ribs. It's actually the posterior inferior serratus muscles that we use in strong exhalations. Like when you sneeze or cough, those muscles constrict at the back to push the diaphragm up to give a sharper exhalation. And depending upon posture or stress, people can be chronically tight in those muscles, especially if they're hyperlordotic or they tilt the rib cage back. Those muscles are constantly restricted. So when you ask the person to breathe into the diaphragm, they basically only breathe into the belly at the front and not into the ribs at the back. And so if you in some way get the ribs to release backwards, again, by lying back, pinning the back to the floor, you're inhibiting the action of those exhalation muscles and then making the space for the diaphragm to breathe in. So you feel the breath move into the back. And the idea of breathing down to the waist is this idea that the feeling of the breath actually extends down to the hips or the waist. So there are different ways of working with that, and also inhibiting the tightness that people can otherwise experience at the back body, which gets in the way of diaphragmatic breathing. There are heart rate variability apps out there, and I don't have any particular recommendation for which one to follow. I know I participated in a test years back where they measured breath, heart rate, as well as oxygenation in the blood. And they basically would put you through a series of math problems in quick succession that would basically put you in a state of stress as you try to solve the problems. And then they would stop the series of questions, pause, and then have you breathe in a relaxed way and measure how quickly you recovered from that state of minor stress back to diaphragmatic breathing. And that was just one thing that I participated in. And they were, of course, measuring people who practice yoga and sports relative to other people. And the more the person practices diaphragmatic breath, the quicker the recovery time and the greater the heart rate variability. I'm going to stop here.
Thank you, everyone, for coming.
Yeah. Thanks for joining me, and look out for the link if you want to go back and review any part of the presentation.